Behavioral Science Diagnostic and Statistical Manual, DSM-5. Section 5, OCD disorders. DSM-4 had the category of anxiety with the following disorders. You had panic, phobia, generalized anxiety disorders, obsessive compulsive disorder, and post-traumatic stress disorder. DSM-5 came along and split the anxiety disorder chapter in 3. So under anxiety disorders in DSM-5, you have panic, phobias, and generalized anxiety disorders. Obsessive compulsive disorders is in a stand-alone chapter, as is post-traumatic stress disorder, which is now called trauma-related disorder chapter. So let's review these disorders. Obsessive-compulsive disorder is a disorder where patients can either have obsessions alone or compulsions alone or both, which is the most common symptom pattern. An obsession is a thought which is repetitive, intrusive, and senseless. It's a thought you don't want to have. For example, you're at a party, there's a pool outside, you get the thought of pushing someone in the water. You really don't want to have that thought, but you can't stop yourself from having that thought. That creates anxiety. That's the obsession. Because no matter how you try to distract yourself, the thoughts keep coming back. The brain then creates the compulsion, which is something that you're doing to neutralize the thought. For example, this could be clapping your hands. So typically the compulsion is a physical act that you're doing in order to stop yourself from engaging in the obsession. So remember, obsessions increase anxiety and compulsions decrease anxiety. The most common defense mechanisms in these disorders are reaction formation, which is what is seen in the obsession, and undoing, which is what is seen in the compulsion. Remember from the previous chapters, undoing was acting out the reverse of an unacceptable behavior. So it was you physically washing your hands, physically checking the stove. Reaction formation is when an impulse turns into its opposite. And that is what you find in the obsession. Now, about 1.5% of the population has OCD, and we find a 3% lifetime prevalence. 50% of these patients do remain unmarried, and this is the only one of these types of disorders under the bigger branch of anxiety that has equal incidence in men and women. Even though OCD and PTSD were removed from DSM under the anxiety disorder chapter, please remember they are still technically considered anxiety disorder. Why? Because they do cause autonomic hyperactivity. And patients who have OCD also have increased episodes of depression. Patients who have OCD have been found to have increased frontal lobe metabolism. They also have increased activity in the caudate nucleus, and the treatment, of course, will be the serotonin selective reuptake inhibitors given for a period of at least 6 months. Hoarding disorder was a disorder that everyone knew about, except it never was a stand-alone disorder. Now in the DSM-5, hoarding disorders is in the OCD chapter. So what is a hoarder? This is the individual who has persistent difficulty with parting of one's possessions regardless of their value. So this is the individuals whose house looks like a dumpster. So you're going to find trash up to the ceiling. If they're walking down the street and they find a pen, they're going to pick it up and take it home because that pen could be useful. If they're walking down the street and they see a manila envelope that's been unused or even used, they're going to take it home because that could also be significant. The things that they have in their home that are of no value, for them they have value. And that's what hoarding disorder is all about. Because of the disorder, you will have a change in your functioning. You're not going to be able to entertain. It's going to affect your family life, and you might not be able to work because of what's happening in your home. Because it's considered part of OCD, the treatment, of course, is going to be with a serotonin selective reuptake inhibitor. Body dysmorphic disorder is a disorder that, if you recall in DSM-4, was in a different chapter, which was the somatoform disorders. DSM-5 came and put it in the OCD section. So body dysmorphic disorder is an individual who believes that some part of his body is abnormal, misshapen, or defective. So they're constantly looking at themselves in the mirror. They see themselves as having something abnormal, so they think their nose is too big, their ears are misshapen, their hands are too small. It is going to affect their day-to-day life, so it does affect their functioning. These are the individuals that constantly will go seek plastic surgeries, and when the plastic surgery is done and they look at themselves in the mirror, they still believe that they have a problem. Do not confuse body dysmorphic disorder with body image disturbance, which is what you typically find in anorexia. Remember, body image is when you believed that you were fat even though you were very thin, whereas body dysmorphic is you believe a part of your body is abnormal. The next section that is new to DSM-5 is the chapter that was created for post-traumatic stress disorder and acute stress disorder. This is called the trauma and stress-related disorders. So when patients have post-traumatic stress or acute stress disorder, these are individuals who've experienced a stressor. These are stressors where you think that you're in a dangerous situation, you're witnessing something horrible, you think that you're going to die. Once you experience the stressor, then you're going to have a re-experiencing of that stressor in the form of a flashback. So you're going to have intrusive recollections during the day, or you're going to have nightmares at night about the associated event. You're also going to experience something called phobic avoidance. So anything that reminds you of the original event, you will avoid. You're going to be having problems with your sleep. Your sleep is going to be very disruptive. You're going to have diminished responsiveness to the external world. You're going to have mood instability where you can be impulsive, irritable, sad, anxious, frequently losing control, having problems with concentration, and headaches. In order for you to be diagnosed with post-traumatic stress disorder, the symptoms must be exhibited for more than 1 month. And this is important because the symptoms are present for more than 3 days, but less than a month, then the diagnosis is acute stress disorder. So let's repeat that. If the symptoms are present for more than 3 days, but less than the month, it is called acute stress disorder. And if it's more than 1 month, it's called post-traumatic stress disorder. Now, what if the question doesn't mention duration of symptoms at all? Then the diagnosis will be post-traumatic stress disorder. Usually these are patients who have had psychologically stressful events outside of the range of normal human experience, such as rape, war, earthquakes, tsunamis, 9/11, etc. So once you've been exposed to a traumatic event, if you have symptoms that occur quickly, then of course that affects your prognosis. Why is it that some people develop PTSD and others do not? Why is it that every soldier does not get it when they come back from the war? Why is it that every woman does not get it after being raped? Well, they believe it's due to some genetic linkage or increased vulnerability. So if you have a lot of emotional variability prior to the stressor, then you would imagine you're going to have increased vulnerability to the disease. Meaning, if you were abused as a child, maybe substance abuser, maybe poor support system, and you are exposed to a stressor, you are going to be at an increased risk to develop PTSD than another individual. Usually adults tend to recover quicker, whereas the young and the old have harder time. Why? The very young have a lot of supports, but they don't know how to access them. The older individuals know how to access their supports, but what's happened, their support systems have gone. You're going to find more PTSD and acute stress disorder in women than you do in men. The number one cause of PTSD in women is rape, and in men it is war. Because this causes sleep disturbances, you will see changes in sleep, such as increase in REM latency, decreases in the amount of REM and stage 4 sleep. And according to research, there is increased sustained activity in the amygdala. Now, patients who have these disorders are going to have increased levels of norepinephrine as well as epinephrine. They tend to have decreased levels of cortisol, and we know that it will have great comorbidities with other psychiatric disorders such as substance abuse, depression, anxiety, etc. The way to treat post-traumatic stress disorder is usually going to be behavioral modification, such as prolonged exposure, and SSRIs or serotonin selective reuptake inhibitors to improve the symptoms of anxiety and hyperactivity. Somatic symptom disorder is the new name for what was formerly called somatoform disorders. These are the disorders where patients are exhibiting symptoms mostly due to psychological reasons. Somatic symptom disorder is one of these disorders. This is what used to be called somatization disorder. And if you remember from DSM-4, this is where you needed to have 8 or more symptoms, 4 pain, 2 GI, 1 sexual, and 1 pseudoneurological. Well, all of that stuff is gone. All you need now for the diagnosis of somatic symptom disorder is at least 1 or more somatic symptoms which are distressing enough for you to cause changes in your level of functioning. These are going to be excessive and disproportionate thoughts, feelings, and behaviors regarding these symptoms. So if I am having chest pain and I cannot function because of my perception of chest pain, it's affecting my work, it's affecting my life, and this has been going on for more than 6 months, then I have what is called somatic symptom disorder. Usually patients are young, and usually patients are female. Conversion disorder is also called functional neurological symptom disorder. This is an individual who experiences a stressor, and as a result of that stressor has symptoms. Now, these symptoms are usually of the skeletal, muscular, sensory, or peripheral non-autonomic system. For example, I witness something horrific, I become blind. I hear bad news, I become deaf. That's what you typically find in patients who have conversion disorder. One of the unique features of conversion disorder is what is called la belle indifférence, which is the beautiful indifference. So even though I may be blind or paralyzed, I am not bothered, I am not upset, I am not distressed by any of these things. And usually, as quickly as these symptoms appeared, these symptoms will disappear. And remember, these patients do not hurt themselves, so they won't fall into a hole, they won't walk in front of traffic. And the treatment is usually individual psychotherapy. Illness anxiety disorder is a new DSM-5 diagnosis for what was formerly called hypochondriasis. Now, these are people who believe, despite constant reassurance, that they have an illness. So they have an unrealistic interpretations of physical signs as being abnormal. They're preoccupied with the illness, and despite constant reassurance, despite CTs, despite MRIs, despite lab tests, despite numerous visits to the doctor, they still believe they have cancer, AIDS, or whatever. And what's important for illness anxiety disorders is that the symptoms are occurring for more than 6 months. This is not just us being in medical school believing that we have a disease, because as we progress in medical school, the diseases change. This is an individual who believes for more than 6 months that he has a disease, will go to the doctor, get numerous tests. And the treatment for illness anxiety disorders is individual psychotherapy. The somatic symptom disorder predominant pain is a disorder where individuals have pain anywhere in 1 to more sites that tends to be severe and prolonged, and they cannot find any medical explanation. Because of the pain, you're going to have disruption in your day-to-day life, and you want to make sure that you're ruling out major depressive disorder. Remember what I mentioned earlier, that especially in the elderly, pain or any kind of somatic symptoms are common in their disorders. So you want to make sure these are patients that are not depressed and are not somatically preoccupied. And always, you want to make sure that there's not a secondary gain here. This is not an individual who's actually a drug addict wanting pain medications. The treatment of this, because it is believed to be psychological, is individual psychotherapy. Factitious disorder is that individual who consciously fakes signs and symptoms, but they don't know why. That is why parts of it are unconscious, which is the motivation, and parts of it are conscious, which is a symptom production. So what is believed to be going on in the patients who have factitious disorder is that they want to assume a sick role. Maybe these were individuals that were sick when they were younger. Now they're craving for attention, and they're going to get it any way humanly possible. So they know what they're doing, but they don't know that it's because of the attention. Usually these patients, when you make the diagnosis of factitious disorder, you have to say whether it's imposed on themselves or imposed on others. If you remember the term Munchausen's by proxy, that was removed in DSM-5, and it is now called factitious disorder imposed on others. So when you fake signs and symptoms for yourself, it's imposed on self, and when you fake signs and symptoms for your child, then it's imposed on others. And typically those patients should be reported because that is a form of child abuse. Malingering or the malingerer is an individual that does not have a psychiatric disorder and illness. This is an individual that knows what he's doing and knows why he is doing it. So these are people that are faking signs and symptoms for an obvious gain, such as money, avoiding military, avoiding going to court, avoiding going to prison, etc. Here we have a table 12-6 looking at somatic symptom disorder, factitious disorder, and malingering. If you notice to the left of the table, there are the terms symptom production and motivation. Symptom production means that you know you are responsible for your symptoms. Motivation means that you know why you're producing these symptoms. Somatic symptom disorders are purely unconscious. So these are people who have something psychologically going on with them, and their brain convinces them that they're blind, their brain convinces them they have cancer, their brain convinces them that they're paralyzed, their brain convinces them that they're going to die from chest pain. They're not faking these things. They truly believe that they have it. They're going to miss work. They're going to go to the doctor. They're going to take medications. They're going to change their lifestyle. So that is why it is purely unconscious. They don't know why they're doing it, so their motivation is also unconscious. Factitious disorder, on the other hand, is that individual who consciously fakes signs and symptoms, but they don't know why. So these are people that are going to the doctor and telling the doctor, I've had fever, chills, blood in my urine. The doctor hands them a cup. They take the cup into the bathroom. They brought a pin with them, stick it in their finger, put the blood in the cup so the urine comes back with blood. So they know what they're doing, but they don't know why. So when you look under the motivation section, it's unconscious. That's why it's still considered a psychiatric disorder. So they know what they're doing, but they don't know why. So factitious disorder symptom production is conscious or intentional, but their motivation is unconscious. Malingering, on the other hand, is not considered a mental illness or mental disorder. Why? Because the malingerer knows what he's doing and knows why he's doing it. If I killed my neighbor because I don't like him, I'm going to tell you that I heard voices telling me to do so. Why am I doing that? Because I don't want to go to prison. I'd rather go to the hospital. So the malingerer is purely conscious or intentional symptom production and purely conscious or intentional motivation. Adjustment disorder is an individual who's experienced a stressor, and as a result of that stressor is going to have symptoms which will affect their functioning to a degree. They're not going to lose total functioning as you would find in the other major disorders, but you will have significant changes in functioning. Once the symptoms start, the symptoms cannot last more than 6 months. You do not give the diagnosis of adjustment disorder if it's because of grief or bereavement. So it cannot be a grief response. That's what grief or bereavement is for. It cannot meet the criteria for another disorder, such as post-traumatic stress disorder, major depressive disorder, etc. So let's review it. Adjustment disorder needs a stressor. You need symptoms within 3 months. And once the symptoms start, They cannot last more than 6 months. For example, you were fired from your job in February 1st. You complain of some depression March 1st, and the depression is gone by April 1st. That would be an adjustment disorder. The dissociative disorders are the group of disorders that use the defense mechanism called dissociation. Dissociation is where you split off the brain from conscious awareness, where you are not aware of what's going on. Usually, dissociative disorders are related to traumatic events or stress in one's life. And there are various types of disorders, including dissociative amnesia, depersonalization, derealization, etc. In DSM-4, there was a disorder under this heading called dissociative fugue. However, DSM-5 removed it as a standalone diagnosis, but it still can be seen in any of the dissociative disorders. So, for example, you can have dissociative disorder with the fugue, you can have dissociative identity disorder with the fugue, etc. What is the fugue? The fugue is that individual who had sudden, unexpected travel. You are unable to recall things about your past, or you could create a new identity. So if I live in the Tampa Bay area, I find myself in Peoria, I don't know how I got there, and I either do not know what my name is, or I've created a new personality. That's what's characteristic of the fugue. So let's review the types of dissociative disorders. The dissociative amnesia is where you have experienced a stressful event, and now you are unable to recall important things about yourself. So something traumatic happened to me. I end up in the hospital. The nurse will ask me my name, and I'll say, I don't know my name, or I don't know how I got here. That's dissociative amnesia. The dissociative identity disorder is the name for what was formerly called multiple personality disorders. These are the individuals who have at least 2 or more personalities, or alters, as they are also called. And you're going to have multiple lapses in memory. For example, I remember going to work on Monday, and then I remember waking up on Saturday. What happened to Tuesday, Wednesday, Thursday, Friday? Well, what probably happened is that my second personality came out, was out during those days, and I was unaware of what was happening during those days. So you will see things described to you in such a way in the dissociative identity disorder. Usually patients who have dissociative identity disorder, you see it more frequently in women, and a lot of them have a history of child abuse, whether it be physical, sexual, or both. And you also see a high incidence of borderline personality disorders with this disorder, since they also have high incidence of abuse.